It's an honor to bring up our next speaker, who will be addressing diagnostic and therapeutic challenges in pulmonary arterial hypertension through pharmacist intervention. And again, an absolute expert in this area. We have Dr. Douglas Jennings. He is a clinical pharmacy manager, heart transplant at New York Presbyterian Hospital at Columbia University Medical Center in New York, New York. Dr. Jennings received his doctorate in pharmacy from Wayne State University in Detroit, then went on to do a pharmacy practice residency at the University of South Carolina, and upon completion of that, went on to do a cardiovascular specialty residency at the Henry Ford Hospital in Detroit, Michigan. Significantly published in the cardiovascular literature. You're in for an incredible discussion. With that, I bring up Dr. Douglas Jennings.
Good morning, everyone. So thank you again, PLN, for the invitation. We'll jump right into this topic. So I have no relevant disclosures for any of the products that we're going to discuss today. Some of our learning objectives that we're going to cover during this talk are to recognize the barriers to a timely diagnosis in PAH and why this can be a very tricky disease to catch. Look at the background pathophysiology and therapeutic targets, and then tie these into how those therapeutic targets are attacked with our pharmacologic armamentarium. Look at the traditional approaches as well as some of the newer drugs as far as their mechanism, safety, efficacy, indications across the spectrum of this disease. And then finally, to look at pharmacy practice strategies to optimize long-term outcomes of patients through an individualized and coordinated effort of care. Great. So let's start off with a patient case. So we have a 43-year-old mother of three who presents with a 2-month history of dyspnea on exertion and fatigue that fits into classification between WHO class 2 or 3. And we're going to come back to that later on. She reports a 1-year history of use of phentermine for weight loss prior to her symptom onset. And she also reports that her mother died at a very young age of 47 from pulmonary artery hypertension. So based on this clinical presentation, family history, and medical history, the patient is diagnosed with PAH, either hereditable versus drug-induced. And this is based on pulmonary artery or right heart catheterization numbers. So this case has a lot in it. We're going to go back and forth and explore the various facets of this patient case on some following slides. So just to distinguish the difference between pulmonary hypertension and pulmonary artery hypertension. And so the nuance and the difference comes from the hemodynamic parameters that are obtained from right heart catheterization. So we can see that anybody that has an increased pulmonary artery pressure is going to be diagnosed with pulmonary hypertension. But the key distinguishing feature for pulmonary artery hypertension, which is a disease we're going to focus on for the rest of this talk, is patients must have elevated pulmonary artery pressures, but a normal wedge pressure, pulmonary capillary wedge pressure, has to be less than 15. So what this means is that the pulmonary artery hypertension is not due to volume overload. So if it were due to volume overload, that would be more suggestive of alternative diseases, most commonly left heart failure. So this is how we distinguish and diagnose the difference between true pulmonary artery hypertension, which is what we're going to talk about for the rest of this talk. So we're just looking at the different classifications of pulmonary artery hypertension. There are 5 different classifications. We're going to talk about class 1. So class 1 PH, pulmonary artery hypertension, falls into those that are either idiopathic PH, hereditable, like we saw in our patient case, those that are due to drug-induced or toxin-induced, which is again similar to our patient case, as well as various other corrective tissue disorders, lupus, Raynaud's phenomenon, Sjogren's disease. There's a variety of these that can be associated with PAH. Type 2 PH, which is the one that I see most commonly being that I take care of heart transplant patients or patients that are pre-transplant, is PH that's owing to left heart failure. And so we're not going to talk about that today. This is a different disease state. PH resulting from chronic lung disease is type 3, so that's most commonly resulting from patients that have long-standing COPD or other interstitial lung disease. Type 4, which we'll touch on very briefly because one of the agents in the talk does have an indication for this, and that's CTEPH, or chronic thromboembolic pulmonary hypertension, so patients that have recurrent PEs. And then PH without any other or unclear mechanism falls into type 5. So we're going to talk just about this top left corner, PH that is true type 1. So we look at drug-induced PH. It's very hard to sometimes draw a tie between a specific drug exposure and the onset of a disease. But these are a couple of the medicines that have been likely or definitively associated based on case reports in the literature to be potential causative factors for PH. So we see a lot of them are stimulants. We see things like dexfluroxamine, various other weight loss products. We see amphetamines, methamphetamines. Dasatinib is a new drug for cancer, for chronic malignancies, and so that's a really idiosyncratic side effect of patients that are on dasatinib. And then we see a couple of other things that are much more, the data is not as robust, but still may be associated with drug-related PH. So looking at the epidemiology, this is considered a rare disease. It only afflicts 15 out of every million people for the true WHO Class 1 idiopathic pulmonary hypertension. We look at the demographics. Unfortunately, it is a disease that does onset most commonly in middle ages, and it is a disease that afflicts females predominantly. We see that 80% of patients are women. 56%, so this was a number we touched on earlier, of these patients will have symptoms at minimal activity or at rest when they are diagnosed. And this is because the delay from symptom onset to diagnosis is over 2 years. And we'll look at a slide later on that has some of the clinical features that are associated or the presenting symptoms, and when you look at those, you'll see why it takes so long to diagnose this disease. It's because it doesn't have any really specific standout characteristics, and it can mimic a lot of other diseases. So that's important to understand. So just to get everybody up to speed on the functional classification, because what are we talking about here when we're saying patients have Class 3, Class 4 symptoms? So this, again, is based on the World Health Organization. So Class 1 are very minimal symptoms, so patients that are able to do most of their daily activities. Class 2 are patients that have symptoms with ordinary exertion. Class 3 are patients that have limited functional class, so these are patients that might get symptomatic doing just simple ADLs like getting dressed, doing light chores around the house. And then Class 4, which is the most severe symptom group, are patients that are symptomatic still even when resting. So just so we have this clear, because when we talk about drug therapies and we talk about the trials and who was in, now we can kind of all be on the same page. So I mentioned this slide. These are the common clinical presentation features of patients when they are diagnosed with PH, or pulmonary artery hypertension. So you see dyspnea is present in about 60% of patients, and then the variety of other things like fatigue and syncope. Some patients might report chest pain, and a very small percentage might have signs of edema. But when you look at these, again, these are very nonspecific. Dyspnea could be asthma, could be pneumonia, could be heart failure, could be a lot of things. And so this is why there's such a significant delay from disease onset to diagnosis. And it's because there's this significant delay that by the time many patients are diagnosed, they have more symptoms that are correlated with advanced disease. So this is an important slide. These are outcomes for patients that have pulmonary artery hypertension. So the blue bar, so what we're seeing here, just that we're all oriented, is that we have the time from diagnosis on the x-axis, and we have survival on the y-axis. So this is a survival curve. So the blue bars are the predicted survival based on the NIH equation, and so this was derived from the 1980s. And we have a slide later on that's going to look at our drug therapy timeline. And when you look back to the 1980s, we really didn't have that much in the way of drug therapy for this disease. So that's why you're seeing what you're seeing. You see that within 1 year, we already have only a 67% survival based on that cohort. And then out to 7 years, only a third of patients were alive at that time based on that predicted analysis. Now, the orange bar at the top is data from the REVEAL cohort matched to the NIH, and the REVEAL cohort was from the late 2000s. And so this data was actually published in 2012, but the REVEAL registry started in 2006. So this is a much more contemporary cohort. So we can see the survival curves are much better. So we've made great strides so far in our drug therapy armamentarium in terms of improving outcomes in these patients. But the key two features that I want you to take away from this slide are, one, that PAH is a progressive disease. And you see that no matter what, whether you're looking in the past or at the current, these patients progress and their survival continues to diminish with time. And that's despite optimal medical therapy. And you can see out to 7 years, still 1/3 of these patients will expire. And we're talking about middle-aged women. So this is still a tragic disease. It's a rare disease. But the two important points from this slide are that PAH is still progressive and it's still a lethal disease. So we have to categorize patients on risk. And so who's low risk versus high risk? So patients that are low risk are those that are not going to have any signs or symptoms of RV failure. They're going to have a gradual versus rapid symptom onset. They're going to have a lower degree of symptoms, so class 2 or 3 versus those that have more advanced symptoms, class 4. Metabolic stress testing is good, meaning their exercise capacity and their body's ability to perform under aerobic metabolism is good. They're going to have minimal to no biomarker elevation and a preserved cardiac index on right heart catheterization. So everybody that has the opposite, they have other features that are on the other side, the right side, would then fall into high risk. So important to look at patients in terms of high versus low risk, because this is going to help us decide which drug therapy we might employ in which patient population. So just to talk about hospitalizations, because we are going to look at some data from some of the more recent trials, and hospitalizations was one of the most important endpoints that they looked at. And why do we care so much about hospitalizations? Because they're associated with a poor prognosis and they're very costly. And this is not dissimilar from other diseases like heart failure. For those of you that work in hospitals, how many of you have sat through a meeting trying to talk about how to prevent readmissions for heart failure? Yeah, probably quite a few of you. So it's the same thing. These are very costly, and unfortunately, though, it represents a sentinel event. So each time a PAH patient is hospitalized, they are going to decline faster in the terms of their disease. So preventing hospitalizations is really important. And when you look at hospitalization costs, these greatly exceed pharmacy costs. So the average cost for a PAH hospitalization is nearly $40,000. When you look at overall health care costs for these patients, it can be up to $8,000 a month depending on which drug therapy that they're taking. So costly disease, but key take home from this slide is that hospitalizations are very bad and we want to try to prevent them. So we're going to look towards drug therapies that have been shown to try to keep patients out of the hospital. So just very briefly going into the pathogenesis before we talk about drugs and where they work and what they do. So what happens is in the beginning on the left-hand slide is that we have exposure or risk. So patients either have one of those diseases, the collagen vascular disease, congenital disease, or they're exposed to a toxin. And what happens subsequently is that we have remodeling of the endothelium within the pulmonary artery. And so this is resulting from decrease in endogenous vasodilators like nitric oxide, prostacyclin, and upregulation of not only vasoconstrictive but also procoagulant molecules like thromboxane and endothelin. And then eventually this will progress, and what we'll have is loss of endothelial functioning, permanent vasoconstriction, and even what you can't probably see there is thrombosis in situ. And so that means microemboli begin to form because of this upregulation, thromboxane, and then you have constriction and low flow. And so when we look at one of the last slides, you see warfarin on there, and this is why warfarin is still sometimes used for PAH, is because some clinicians still feel that this thrombosis in situ is still important, an important part of this disease. So with that in mind, now that we've looked at the various molecules that are involved, of course we have different drugs that are going to try to counterbalance this deleterious process, this harmful pathophysiology, through various mechanisms. So there's 3 different pathways or 3 different buckets that you can think about for your drug therapies. So on the left-hand side is the endothelin pathway. And so we have a variety of drugs that work on this pathway. So endothelin is an important vasoconstrictor, and so these drugs work to block those receptors to promote vasodilation within the pulmonary artery. They either work on endothelin receptor A, B, or both, and these are the ERAs, or the endothelin receptor antagonists. So we'll look at those drugs later on. The middle pathway is the nitric oxide pathway. We have a variety of ways to modulate this. So there's a new drug, Riociguat, that's a soluble guanylate cyclase inhibitor, and that works to modulate or beneficially stimulate the body's own endogenous nitric oxide system. And then we also have the phosphodiesterase 5 inhibitors, and so they work to prevent the breakdown of nitric oxide within the pulmonary vasculature to promote vasodilation. So just thinking about that, you're going to see later on that this is a combo that you're not going to want to use, right? You're not going to want to combine a PDE-5 inhibitor with Riociguat because they both go down that middle pathway. You want to try and pick drugs that are complementary from one of these three. And then finally on the right-hand side is the prostacyclin pathway, and these are actually the first medicines that came about. So the first class, the oldest class, are the prostacyclin derivatives like epoprostenol and treprostinil. And then we have this new drug here, the selective IP agonist. And so this is a prostanoid-like drug that works on the same receptor but is not a prostacyclin. And we'll come back to that later on. So again, briefly, just to go through the timeline. So again, through the 60s and the 80s, we really didn't have anything except non-selective vasodilators, mostly calcium channel blockers. And then as time goes by, the biggest breakthrough was in 1996, was with epoprostenol. So that was really a watershed moment when we had the prostacyclin derivative because that really changed our ability to manage this disease. And then in 2001, we had the first oral agent, Bosentan, approved, which again was a big jump in therapy because the prostacyclins are all parenteral. Then we had some other prostacyclins, treprostinil came out, and then sildenafil came out in 2005, and that was the second class of oral agents. I'm sure you're all familiar with the commercials that sildenafil has a different indication, the more common and more familiar one. But this was what it was actually studied for, and that serendipitous side effect that they found in clinical trials was the birthing of Viagra. But they were studying it for PH. Then we have a couple other endothelin receptor antagonists, ambrisertan, and then really you see an escalation lately. And so in 2013, we had 3 drugs come out. We had Riociguat, Macitentan, and treprostinil by mouth. And then in 2015, we had Selexipag, which is the latest drug that's been published or produced, and we're going to look at the data that was published that got that drug on the market and where it might fit in. So important, before we start talking about these drugs any further, let's think about our treatment goals. So what are the treatment goals that we want to achieve in these patients? We'd like them to have minimal symptoms, if possible, so functional class 1 or 2. We'd like them to have a 6-minute walk distance somewhere between 380 to 440 meters. And that's because it's a prognostication tool. Patients that are able to walk that far tend to do better. We'd like to normalize RV function, normalize biomarkers, and again, prevent hospitalizations because we know that hospitalizations are tied to clinical deterioration. If we can get their oxygen consumption up, great. So these are some of the treatment goals that we have for these patients. What about treatment failures? And so this data was taken directly from one of the clinical trials that we're going to look at later. So when you hear me talk about treatment failures, this is what it means. So it means any hospitalization for worsening PAH. And that could mean needing a new drug therapy, needing listed for heart transplant, or having to undergo a procedure called an atrial septostomy, which is used to just kind of relieve pressures on the lungs. Disease progression means a 15% or greater decrease from baseline in the 6-minute walk test or progression of their symptoms into the class 3 to 4 realm. Or unsatisfactory long-term clinical response means a decrease in baseline from their 6-minute walk or up to class 3 symptoms. So that's what it means when we talk about treatment failures. So now, diving into the drug therapies, we're going to start with the oral therapies, and we're going to look at the PDE-5 and the ERAs first. So the PDE-5 inhibitors have been around the longest, and the 2 medicines that are available and indicated for PAH are sildenafil, which is branded as Revatio or Revatio, depending on which part of the country you're in. And again, this has been indicated to improve exercise capacity in early-stage PAH. It's 20 milligrams. Unfortunately, it's a 3 times a day drug. There is an IV dosage form, and I do use that occasionally in the ICU, but not very often. Tadalafil, or Adcirca, is a second drug in this class that also improves exercise capacity. The nice thing about it is that it's only 40 milligrams once a day. But again, you have to be careful about patients that have concomitant renal or hepatic impairment, and it's actually contraindicated in patients that have severe renal impairment, creatinine clearance less than 30. This slide's a little busy. This has all of the different ERA medicines. And so what we look at, we'll look at the first 3. So the first 2, rather, is Bosentan and ambrisertan. These are both improved for indication of improving WHO classification. And Bosentan was the first one that was approved, so it's a BID medicine, so patients have to take it twice a day, and you have to start slow, titrate up to a goal dose of around 125 twice a day. And this is a dual agonist of both types of receptors. And a key thing for all of these medicines in the ERA class is that they all have REMS programs for a variety of reasons, so that patients have to be entered into a registry. And so the trachlear registry is required for this medicine, and the REMS is due to the potential for teratogenicity as well as for hepatotoxicity. And so patients have to be very closely monitored for potential liver injury, and women of childbearing age have to be counseled extensively about not becoming pregnant while taking this medicine. Ambrisentan is daily medicine, which is nice. It's 10 milligrams daily, but again, still has a REMS program for Letairis, and it's for the same reasons. Macitentan was the latest drug in this class that was approved. It has some different pharmacologic features. It's a bit more tissue selective for the receptors, and it's more lipophilic, so it may have better penetration into the site of action. And it is a dual agonist. It is once a day, and it does have carried indication for delaying progression of PAH. And so that's new, and that's a distinguishing feature. And we'll look at some of the data from the clinical trial with that drug. But again, just like all the drugs in this class, that REMS program exists for the same reason. So be careful of that when you're thinking about these medicines. So this is the Macitentan data, and this was from the Seraphin trial, which was the main trial that got Macitentan approved. And so the key thing to really look at here, which you probably can't see, is that there was a significant reduction in worsening of PAH and hospitalization for PAH. And they had two doses that they studied, a 3 milligram and a 10 milligram. We saw on the previous slide the 10 milligram is the dose that got approved. And so this was really a big difference because other medicines hadn't shown this. And so we've talked about how hospitalization for PAH is a very big thing. Well, here we have a medicine that was shown in a randomized clinical trial against placebo to be able to prevent patients from getting hospitalized. Now, we look down, the signal was here for a reduction in mortality due to PAH. The p-value was 0.07, and there were only 250 patients in the trial in each arm. So it's even possible that if they had enrolled more people, we might have found a medicine that has a mortality benefit, but they did not reach that endpoint. But nonetheless, they did show reductions in hospitalization, which we know is a very important outcome. So switching gears to the prostacyclin analogs. So each of these drugs carry a very unique delivery device, and these are pictures of some of them here. And that's because most of, not all of the prostacyclins are parenteral or inhaled. So there's only one that's available orally, and it's not used that commonly. So this is a big drawback to this drug class in general. So all of these medicines have to go through specialty pharmacy. Again, lloprost, here we see the specific delivery system that patients have to have in order to take this medicine. So the parenteral prostacyclins, epoprostenol, again, was a really watershed moment. And you see that this carries an indication for patients that have WHO class 3 to 4. Unfortunately, it has a short half-life, and because of that, patients have to keep a backup cassette in case they happen to run out. It used to be very difficult to manage because it was thermo-unstable. If it needed to be kept on ice. There's a thermostable version now, Velitri, that's at least a little easier to manage. Treprostinil had some advantages over this, both sub-Q and IV, that it has a longer half-life of 4 hours, and it was stable at room temperature. But again, patients still have to carry around a backup cassette. And whether or not it's sub-Q or IV, they still are tied to a medicine, just like I'm tethered to this right now, that has a constant source of a drug that could also be a constant source of infection, and a variety of other drawbacks. So they moved on to inhaled drugs. So lloprost and treprostinil can both be given inhaled. But what's interesting, important to notice, the lloprost has to be inhaled 6 to 9 times per day. So you're not tethered to an IV anymore, but now you're tethered to this inhaler. And even the treprostinil inhalation has to be inhaled at least 4 times a day. So just important to mention, still, it's much better than having an IV potentially, but there is a drawback that there are many inhalations every day that patients have to take. So we've tried to move into some newer therapies, and all of the medicines that we're going to finish talking about now are oral therapies. So Riociguat, we've already touched on, has a unique mechanism of action. So it modulates the body's own endothelial system, and so it stimulates soluble guanylate cyclase, which eventually upregulates cyclic GMP, which is a very important vasodilator in the pulmonary vasculature. We also see here on this little cartoon PDE-5 in the bottom. Remember, phosphodiesterase 5 is the enzyme that breaks down cyclic GMP. And so we like to inhibit that too with phosphodiesterase 5 inhibitors. So this is a recap of how those drugs work. And again, a second reminder that we wouldn't be combining Riociguat with a PDE-5 inhibitor since they both work on the same pathway. So this was just some of the data from the Riociguat trial. And so what we're looking at here is change in 6-minute walk distance over time. And so this is time measured in weeks. And so this was against placebo. And so we can see that there was marked improvement in 6-minute walk distance with this drug versus placebo. And so what was the drug eventually given indications for? So it's indicated to improve exercise capacity. They did find that in the trial, in addition to 6-minute walk tests, that patients' functional classification felt better. They felt better through their functional classification, and there was a slight delay in the worsening of symptoms. And because of this, this trial also included type 4 patients. So this is the only drug that has that indication for class 1 and for class 4, which is, again, the chronic thromboembolic PE patients. So it can be used in those patients. Unfortunately, it does have a TID dosing schedule, so you have to start at 1 milligram PO TID and then up titrate every couple weeks to try to get to your target dose, and that's limited by hypotension. And we do have an adverse effect slide for all of these drugs, so rather than kind of give it to you piecemeal, I've got a summary slide with all the adverse events and drug-drug interactions. Again, just like one of the other medicines we've talked about, you can't use this in patients with severe renal impairment. And similar to the ERAs, this drug also is teratogenic, unfortunately. And again, thinking back to who this disease afflicts, it's middle-aged or younger women of childbearing age. And so we have another drug that is potentially, or is rather, teratogenic. And so this has a REMS program as well, the ADAMPAS REMS. And those are regulated by the FDA. And I will warn you, those of you that work in hospitals at least, we were recently audited for this to make sure that we were compliant with our REMS for this particular drug. So that hadn't happened before. So just a word of caution that make sure if you're in a hospital that uses this medicine that you're compliant in documenting the things that need to be done for the REMS program. Lastly, we have oral treprostinil, and so this drug is used seldomly because in the clinical trials the data was frankly underwhelming. So again, we have a TID medication. Really where this fits in, if you have a patient who's on either sub-Q or IV treprostinil, who you're able to wean down to a very low dose, which suggests that they have minimal symptoms, you could try maybe transitioning them over to this oral drug. But otherwise, I really don't see this drug used very often in clinical practice. So this is the last new drug we're going to talk about. This is Selexipag, and so this is the selective IP receptor antagonist. And so this is a particular type of prostanoid receptor that's found in the lungs. And so again, this is similar in terms of its mechanism of action, but it's not a prostanoid. So it's not like epoprostenol, it's not like treprostinil, but it works in a similar fashion. And this drug, again, carries an indication to delay disease progression and reduce the risk of hospitalization. So this is the second drug that we've talked about today that carries that specific indication. And again, that was based on the data that was seen in the clinical trial. Dosing is a little complex. You have to start at 200 milligrams twice daily and up titrate weekly as tolerated. And your goal dose is actually 1,600 mics BID. So you can see it can take some time to get patients up to that maximum tolerated dose. So this was the data from the Gryphon trial, the clinical trial that got this drug approved. And so again, what we're seeing in the top there, what we have is statistically significant reductions in hospitalization or worsening PAH, disease progression, and death was not different, but really there were very strong trends and major differences in disease progression and hospitalization. And so again, that's really important. That's really what we're trying to get from these drugs when we're treating patients with PAH. So adverse events. We've talked about all the good things: disease progression, functional class, keeping patients out of the hospital. What's the bad? So the bad side, the side effects, so the PDE-5 inhibitors and Riociguat, because they have similar mechanisms, you're going to see similar side effects. So headache, hypotension, dyspnea, flushing, epistaxis, because it is a mild antiplatelet agent. Visual changes, because PDE-5 is not distributed solely in the lungs, and the drug itself is not 100% selective for just PDE-5. And so there are other PDEs in the eyes and in other places, and so be wary of that. And again, with Riociguat, we have teratogenicity listed there. ERAs, we have similar side effects: headache, flushing, edema. Transaminitis, we talked about liver injury and teratogenicity, and that's why these patients need to be in a REMS program and need to be monitored very closely. The prostanoids and selexipag, again, have similar mechanisms of action, so you expect similar side effects. And this is actually how these drugs are initiated. Patients are brought into the hospital, usually in the ICU. They're started on IV Flolan or IV Velitri, whichever epoprostenol form you might have, and then we slowly ratchet up the dose until the patient has a side effect, and then we back off, and that's the dose they'll usually stay at. So what are those side effects? It could be nausea, vomiting, diarrhea. Jaw pain is a common one. Headache. Hypotension is a big problem. And so we see very similar side effects from selexipag, again, because this drug works in a similar way. So headache, jaw pain, nausea, vomiting, and flushing. In addition, any of those parenteral forms, again, we're talking about a constant IV line or a sub-Q port, so we can see injection site pain, swelling, and with the IV catheter form, we can see bacteremias and even thrombosis. And there does seem to be an increased risk for gram-negative bacteria that we're noticing, and this does seem to be more prominent with the treprostinil form as opposed to the epoprostenol form, and this might have to do with the diluent that one drug uses versus the other. And again, if you're going to use these parenteral drugs, you have to have extensive education, training, and support for these patients in order to make sure that they know how to keep their backup cassette, keep it on ice, take care of all these things. Drug interactions, so it's pretty similar for most of these drugs. Many of them are 3A4 substrates, so PDE-5 inhibitors we have to watch out for. If you aren't aware that you can't take sildenafil with a nitrate, then you haven't been watching TV for the last 10 years, because that's in every Viagra commercial, or drugs in that same class. Alpha blockers too. So Riociguat has a similar problem with P-glycoprotein and strong 3A5 or 3A4 inhibitors. And again, we don't combine Riociguat with a PDE-5 inhibitor. ERAs go through 3A4 and 2C19, so we have to watch out for that. Bosentan has a couple others. The prostacyclins, really, we're worried just more about vasodilators, of the risk of concomitant hypotension, so be careful with that. The idiosyncrasy with selexipag and with the prostanoids is the 2C8. You don't see many drugs that go through 2C8, so something to keep in mind just to double check, because I can't think of many other drugs that do, so just make sure that you don't end up on that combination, and that's actually why gemfibrozol is listed on this slide, because gemfibrozol is actually a 2C8 inhibitor. Who knew? So we've talked about the drugs up to this point that actually treat the disease. Some patients are on supplemental therapies. Diuretics can be used to help control with volume. Digoxin, not really indicated, although you might still see some patients that have had the disease for a while, or clinicians that have been practicing for a while may still think about digoxin for RV failure. And then warfarin, we mentioned. You might still see patients on low-intensity warfarin, and the thought process is, again, to prevent that thrombosis in situ, that microthrombi within the pulmonary artery that can form with this disease. So back to our patient case. Again, we have a young lady who has a 2-month history of dyspnea and is diagnosed with PAH. So based on this, we have a young lady recently diagnosed with PAH, functional classification 2 to 3. And so which medication would you recommend? PDE-5 by itself, epoprostenol alone, an endothelin receptor antagonist, combo therapy, or an inhaled prostacyclin? Okay, so many of you would choose a PDE-5 inhibitor alone, and this is a very reasonable choice because, again, this is one of the few drugs that isn't teratogenic. We have a young lady, she's already had 3 children, but we're not sure if she wants more. But also the drug is relatively safe, well tolerated, and the patient has functional classification, lower functional classification that fits in with where this drug would fit. So that's nice. A few of you did pick 4, which is interesting, and that's actually where we're going with the next few slides. And so I'm glad to see that a few of you thought about combo therapy. So what do the guidelines actually say? So the current guidelines are a little old. They're from 2013, and so we expect some things to change. But so basically there's a strong recommendation for any patients that have advanced disease, so class 4, which they get started on epoprostenol IV. So anybody with advanced disease is going to get epoprostenol. In patients have lower classifications 2 or 3, you can probably see a lot of words here, but you can't actually see what they are. It basically means dealer's choice. So pick one of the oral therapies that you want to use. The reason that Macitentan is in yellow or it's in a different font is because, again, remember, that's a drug that has clinical data for reducing hospitalization. So it has a different font because the guideline authors recognized that there's outcomes data with Macitentan where there isn't with the other agents. But then there's this approach to PH. Do you follow the guidelines straight up? And that's where this gets confusing. So there's this concept of sequential therapy. So you follow the guidelines. You pick any of those choices that I gave you. And let's say you pick a PDE-5 inhibitor. Patient deteriorates, then you add on an ERA. Patient deteriorates, you switch to Flolan. And then if they further deteriorate, you switch to maybe lung transplant or some other kind of therapy once they failed ERA. But there was a trial that's been published since the guidelines came out, which was the Ambition trial, that looked at upfront combo therapy with tadalafil plus ambrisentan, so an ERA plus a PDE-5 inhibitor, which was the choice 4 that some of you picked, versus monotherapy with either, and they found that there was this very significant reduction for the composite of clinical endpoints in favor of combo versus monotherapy. So where this is going to go is going to be very interesting, because this suggests that upfront combo therapy might actually be best. But remember that neither of the drugs used in this clinical trial were drugs that had endpoints by themselves, because Macitentan and Selexipag are the drugs that were proven superior to placebo for keeping patients out of the hospital alone. So when the guideline authors go back and tackle this, what they're going to have to decide is it better to use upfront combo with 2 lesser drugs or 1 potentially superior drug. And we don't have any comparison between those 2 strategies, so we really don't know. Just a few closing thoughts on specialty pharmacy. So this is obviously important because these medicines, the IV ones, even the oral ones, because of the REMS capacity, they have to be used. And so this is going to help us with clinical counseling, support, nursing training, helping getting prior authorizations, and then delivering the medicines to the patients. Med safety is a big thing for us as pharmacists, and really depending on where you are, it doesn't matter. If you're involved in dispensing of these medicines, either inpatient or out, you have to really focus on determining how you're going to do vigilance. Is it going to be through order sets? Is it going to be through smart pumps? Is it going to be through pharmacist double check, nursing education, etc.? There's very extensive med safety, and there's a nice paper referenced here that I could share if people want, that one of my colleagues authored on how to ensure that these medicines are used safely. And then again, patient counseling. So what do we tell our patients? Expectations from treatment goals. And so that's why I spent some time talking about treatment goals so that you as pharmacists can explain to your patients what to expect from these drug therapies, how to dose them, how to administer them, if they have a catheter site, how to take care of that, what sort of symptoms, adverse events to expect, and then again, just basic health maintenance with these patients, getting the right diet and exercise, yearly immunizations, and for the teratogenic medicines, making sure that, again, we talk about contraception in those patients. So clinical pearls, we have improved outcomes greatly in PAH through advances in drug therapy, and we saw that on that slide, the one where we looked at the NIH data from the 80s versus the contemporary data from the Reveal Registry. So we've made great strides, but it's still important to recognize that this is still a disease that is progressive, and lethal. And so we still have more room to go in terms of our expanding our pharmacologic therapies to potentially tackle that. However, we have had 14 FDA-approved medicines that are now on the market, and there are others in the pipeline. And we as pharmacists are very well poised to be essential elements of the healthcare team to develop safe and effective care for these patients. We'll see. All right. So at this time, I think I'm done, and so I'd like to thank you all for your time and attention.